Good evening, everyone. It's on behalf of Tropical Medicine Subcommittee of Clinical Infectious Disease Society. It is my pleasure to invite all of you to this panel discussion on approach to acute febrile illness. Myself, Dr. Kavita Sarau, Professor and Head, Department of Infectious Diseases at Kasturba Medical College, Manipal, and Chair of Tropical Medicine Subcommittee. I will be the moderator for this panel discussion. Acute febrile illnesses are very common and sometimes can be challenging. It can be mild and self-limiting to a very fatal illness. We all need a framework when we manage patients with acute febrile illness. Doctors who are practicing in primary, secondary, and tertiary, all levels of healthcare are faced with this challenge of acute febrile illness and manage with varying diagnostic facilities available and with varying resources available. So to discuss an approach to acute febrile illness, we have eminent panelists. Dr. Ajaz Nabi Kaul is the Director of DNB FNB at Sher Kashmir Institute of Medical Sciences, Kashmir. Dr. Camilla Rodriguez, Consultant Microbiologist in PD Hinduja Hospital, Mumbai. Dr. Anurag Bhargava, who is a Professor of Medicine at Yenapaya College, Mangalore. Dr. Swati Rajgopal, who is a Consultant in Infectious Disease and Travel Medicine in Bangalore. And Dr. Bibhuti Saha, who is the Professor and Head of Department of Infectious Disease and Clinical Microbiology at School of Tropical Medicine, Kolkata. These are the eminent panelists who will be teasing out the approach to acute tropical febrile illnesses. We have 4 presenters who will be presenting 4 cases of varying type to the panelists, and we'll discuss as the cases are presented. To begin with, I have a few announcements. I request all the participants to mute themselves, the microphones, and to close all the videos and audios on their desktops. And to kick off, I will ask one question to Dr. Ajaz. Sir, what is the definition of acute febrile illness? Because at different places it's mentioned differently, and the participants would be interested to know what exactly is acute tropical febrile illness.
Thank you, Dr. Kavita, giving us the chance to moderate and have this program today, because our Clinical Infectious Disease Society is very much particular about spreading the awareness as well as teaching, and this one program which was sorted out by our subcommittee some time back. So I found it a right time to start the discussion. There have been varying definitions of AFIs, and there is some difference between the time frames and between the West and between our community. But if we take majority of the literature from the European and American data, acute febrile illness is defined as a fever of more than 38 degrees centigrade, which is presenting to the ER department, which persisted for 2 to 7 days without a localizing sign to any particular symptom. But if we go to our own country and we find that there is a definition given by All Indian Institute of Medical Sciences, a good article came of theirs in JAPI, and they define AFI refers to patients presenting with 38.3 degrees centigrade equal to 101 degree Fahrenheit, lasting for more than 2 days, but usually less than 14 days, with no definitive localizing symptom or sign. This was from AIM. So there is partly a difference of in the West, they take it usually a 1 week. But for South Asian context, particularly in India, we take around 2 weeks, from 2 days to 14 days. So I think any febrile illness, which is of less than 2 weeks duration, without a localization to any symptom or to any system or any sign which is localizing to any system, so we should qualify it as an AFI. And that should be our prudent approach as a first step towards it.
Okay,
I think.
thank you. So India is such a diverse country and so many regions, and the causes could be so very different. I would like to ask Dr. Bhargava, what are the common causes of acute febrile illness in India?
Thank you, Dr. Kavita, for that statement. And now we have more reliable information in the last few years. So there have been some multi-center studies done in India, across India, for the spectrum of pathogens causing AUFI. So the most common 5 are actually malaria, dengue, followed by rickettsial infections like scrub typhus, leptospirosis, and enteric fever. And the prevalence of these infections may vary according to the place, but these are the most common pathogens causing this thing. And in particular, we need to be aware of the prevalence of scrub typhus across India, and it has a particular seasonality which overlaps with other ones. But we have quite a mnemonic also to remember the common causes, and we call it MAESR. Malaria is to be ruled out first, followed by arboviral infections, which could be dengue, chikungunya, Zika, and other ones. And then followed by enteric fever, spirochetal infections like leptospirosis, and rickettsial infections, which includes scrub typhus. So these are the common ones. Of course, in any particular setting, typhoid may be more common in the third, after this, but this is the predominant spectrum. And in particular, for the first 2 in this list of MASR, it is easy to establish a diagnosis because you have reliable diagnostic tests for both malaria and dengue. So once these are excluded, then you have non-malarial fevers, which then are this typhoid, spirochetal, and rickettsial. Of course, influenza may sometimes present without very prominent respiratory symptoms. And in this, and again in studies, it is shown that influenza also, particularly during outbreaks, should be recognized as one. And of course, after COVID, now we have other possibilities also. Thank you.
Okay, Bhargava, moving on to Dr. Swati. What are the chief ruling in and ruling out findings, for these common tropical febrile illnesses?
Yeah, thanks, Dr. Kavita, for having us as panelists. But I think this is a very complex topic because as much as we have so many guidelines, we have so many papers that is there, when it comes on bedside, there's so much of overlap of symptoms that makes it sometimes quite difficult. So when you have to categorize it, first look at all the symptoms as a bedside person would do, whether you look at fever, myalgias, headaches, conjunctival suffusion, as well as a rash. Now, very important in most of these symptoms that you would look at, people classify it as different ways. The way that you look at, or the way I keep in my head, is basically when you look at fever, rash with thrombocytopenia, if you want to look at it that way. So if you're looking at people, say, for instance, like dengue or malaria, for instance, so obviously you will have more of fever, rash, body pains, but you could also have something of thrombocytopenia sort of swaying towards infections like dengue. But in case if you have someone who has very pronounced arthralgia, so if you have a very high-grade fever with severe arthralgias which are debilitating, obviously think along the lines of chikungunya. Enteric is a very tricky phenomenon because depending on the phase of the illness, when you look at it in the sort of the first week, second week, third week, you would look at it with high-grade fevers. You could look at hepatosplenomegaly, thrombocytopenia, and sometimes if you have an eye for a lot of rash or the color of the rash, sometimes you could see the so-called red spots, but rash is something which is not sort of so prominent for us. Leptospirosis, very, very common, where you sort of, the rash is not a very dominating fever.
So we would like to go by syndrome wise, right?
Yeah.
Different fever with rash, fever with arthralgia, fever with liver dysfunction, fever with the acute kidney injury, so on and so forth. Dr. Vibhutisa, sir, what are the chief clues from simple laboratory tests for us to move in a particular direction? Like, for example, CBP or liver function test.
Yeah, So first, as has been already discussed, we take a good history and we do a thorough examination of the patient. And the baseline test we'd like to do is a complete blood count and a malaria parasite. RDK, if it is negative, you can repeat after 12 hours, or better is a thick and thin films. Then comes dengue, depending on the symptoms. So you check for dengue. Dengue, you have, if it is in 5 days of illness, you test for dengue NS1. Dengue NS1. You do a dengue NS1 antigen test. Someone is speaking.
All the
anyway,
participants, please keep your microphones muted. Thank you.
वो आपने साइलेंट पे कर रखा है, वो पीछे पड़ा है आपका वो.
Ruth, can you mute them?
Yes, ma'am. I'm fine.
I have muted them, ma'am. Sorry.
Okay, thank you.
Yeah.
Then going on, so you have done tests for malaria and dengue and a complete blood count. And then, of course, depending on the whatever you are getting, you would like to go for a organ function. If you are thinking, seeing clinical jaundice or any nausea, vomiting, a lot of that, so you can go for a liver function test. And if you find urine and a routine urine examination, if there are urinary symptoms, and if there is signs of like that, you can go for kidney function test. And the respiratory symptoms, you go for chest X-ray, pain abdomen and all that, you go for ultrasonography. So these were depending on the symptoms. And I think we should not waste, we should not be doing a lot of tests at the first point of time. Depending on the presentation, clinical features, and prevalence of the diseases in that part of the area where the patient is presenting, we should go serially for the tests. And of course, the blood culture and urine culture if you are going for that. Thank you.
Can't hear. Kavita, we can't hear you. You're muted.
Kavita, please unmute yourself. Kavita, unmute yourself.
Ma'am, how do we apply diagnostic stewardship principles in acute febrile illness?
I think diagnostic stewardship means just don't keep doing syndromic PCRs for everybody. I think especially from a basic perspective, you see the organism with microscopy. You would grow the organism if you are suspecting a bacterial infection with culture. I don't think for viral infections, we have the bandwidth to grow an organism. We do rapid tests for antigen. We'd look, especially in AUFI, we would look at IgM serology. And the last is multiply the organisms by molecular tests. And I think to this end, the CBC is really a useful test because it actually triages the four main illnesses: enteric, malaria, dengue, and lepto. High count, think lepto; low count, think malaria; or absolute eosinopenia, think enteric; and low platelets would be dengue. So you can get a lot of information just by the CBC. Yeah.
Okay. I request now Dr. Venkat to present the first case, and Dr. Ajas will discuss this case.
Yes, ma'am.
Dr. Venkat.
Yeah, I'll just start sharing my screen and hope you can see the screen, ma'am.
Yes, we can see and hear you.
Yeah. So I'll begin with the case. So this was a 14-year-old male. The history was obtained by the relatives for reasons which will be quite clear. The patient was not able to give the history. He traveled to Muscat for, this is in 2019. So he had traveled to Muscat for 15 days in June, and he had returned 2 weeks prior to the admission. So he was seen by a local pediatrician on 8th of July, 2019 for a kind of extremely short duration of fever, 3 episodes of loose stools, watery eyes, and a stuffy nose. Was diagnosed to have a viral fever, and pediatrician had mentioned there was, he thought it was dengue. So he was not prescribed any antibiotics and was explained about the warning signs. Also at the same time had arthralgia and myalgia, no cough or phlegm, no altered sensorium or headache. On the 10th of July, he started to have vomiting. He was feeling more unwell and had shortness of breath upon exertion. On the 11th, that is the date he was admitted with us, he had worsening of hurried breathing and sudden onset of altered mental status, agitation, with possible seizures and was admitted at 5:15 p.m. on 11th of July 2019. So basically, this is a young boy with what looks like a acute undifferentiated febrile illness with some diarrhea, upper respiratory symptoms, myalgias, body ache, with recent worsening status and altered sensorium. So the prominent findings in the fever, in the physical, in the history were fever, arthralgia, myalgia, some kind of a meningoencephalitis. And when he was brought to the ER, he was in shock. So I'll just stop here for a second so that the case can be discussed at this stage.
Dr. Ajas, your comments?
Dr. Venkat, thank you very much for giving a very crisp summary. You see, if we divide our patient into two parts, part A, if he had just fever and loose motions, plus minus upper respiratory symptoms coming from a overseas flight after some days, so a salmonellosis can be kept as a first differential diagnosis. He had some pain abdomen, some loose motions. But then over the course of period of time, he had acute deterioration over 2 to 3 days. That means from 8th of July to 13th of July, once he was admitted to you. So that means during that time, a quick leakage has probably, due to the capillary leak syndrome, has started, and he has developed a respiratory involvement. He had a breathlessness, and then he had some abnormal movements. He had an alteration in mentation, as well as, according to you, he was in shock.
Right.
So once he is coming from outside India, especially from the Middle East, so there are certain things which are hovering in our mind, whether it was a short duration, could it be a dengue, could it be malaria, where involvement of lungs and shock can go into a severe malaria with a cerebral malaria? We don't know. Second possibility. Third possibility, obviously, has a arthralgias, myalgias, a chikungunya-like syndrome could be a possibility. There are certain viruses which are very peculiar to the Middle East, like Rift Valley could be a possibility, Crimea, Congo, because now investigations will tell us whether he has a bone marrow involvement, he has a coagulation disorder taking place at the same time, and a workup about his cardiac and a pulmonary status. I think that should be the way we should look it ahead. So the part A, which was up to the pediatrician, it has crossed that line. It has come to a ID level. And I think with a full-blown, as you have rightly put it, fever, meningoencephalitis, myalgia, arthralgia, and shock, it has broadened a differential diagnosis into a very severe critical illness. So I think you can put forward investigation so that we can discuss it in a better way.
Yeah. Thank you very much, sir, for your inputs. Yeah, one point I would like to mention here is that the travel history is very important, but he had returned to Hyderabad 2 weeks prior to the admission. So we need to keep in mind the incubation period of those organisms.
So the dengue will be a little less. Dengue will be a little less.
Yes.
Definitely, rather it will go down the list.
Right.
So the clinical profile is not typically fitting into malaria, because he had a loose motion, he doesn't have a rigor, he doesn't have 3 days, second day rigor, chills. So it will also go down the list, right? A complicated enteric can be a possibility. He had a typhoid, he had a loose motion, salmonellosis, which culminated into an enteric-like situation. And it's a complication which can involve DIC, involving enteric, involving HLH, involving enteric. So it could be a enteric which is causing this, or any of the odd organisms which are very much particular to that region. I will keep them into my differential diagnosis.
Yes, sir. Thank you very much, sir. I'll proceed to the examination. So this was when he arrived in the emergency room. Actually, this shock syndrome, we obviously cannot say from the history, but he was clearly in shock with a systolic blood pressure of 60 millimeters of mercury. And what we could gather from the emergency department notes was that he was intubated and mechanically ventilated because of severe respiratory distress and hypotension. He was very agitated and irritable with cold, sweaty extremities and a feeble pulse. So immediately they had done a bedside echo, which looked normal. Arterial blood gas, as you can see, very high lactate, and it is mixed metabolic acidosis with respiratory alkalosis with a base excess of minus 15.1, bicarb of 13.6, lactates of 6.3, clearly because of the severe shock. So this is the ECG findings. As you can see, there are STT changes which are quite widespread. I think it's evident in all the leads.
Yes.
Right, sir. So the initial exam showed a complete blood picture hemoglobin of 12.9, total leukocyte count of 6,100, platelets of 2.09 lakh, differential count of 63%, neutrophils 35% lymphocytes. The smear and antigen for the malarial parasite was negative. Dengue NS1 antigen was negative. Creatinine was 1.71. Liver enzymes, ALT was slightly elevated at 62. Uric acid, probably because the acute kidney injury was elevated at 10.2. I think the initial chest X-ray just showed some bilateral interstitial infiltrates, not anything significant. So here again, if you have to summarize the history and the exam at the time of evaluation in the emergency room and the basic, very basic workup, which we got in a couple of hours. This is a young child with acute febrile illness, myalgias, with some myalgias and arthralgias, but predominantly with a shock and what looks like a encephalitis-like syndrome, normal white cell count, smear and antigen for malarial parasites were negative. So, sir, anything more that you would like to consider given these initial exam and lab findings?
Would you put a possibility of a myocarditis associated with it?
Yes, sir. Actually, yeah. Because this was just in the emergency. We were waiting for the cardiac enzymes to come back, but they were elevated. Yes. So there is definitely a myocarditis involved. There's no doubt about it.
What has been his saturation at that time?
Yes, sir.
What has been his saturation at that time? Saturation.
Saturation was fine, sir. Actually, the lungs were as such okay. If you see the arterial blood gas also, PaO2 was 146. And I think the P/F ratio was more than 300. So there's no ARDS per se. I mean, there doesn't seem to be a pneumonia syndrome as such.
Correct. I think your possibilities are very well taken with the addition of myocarditis.
Right.
So a little widening of the syndromic diagnosis. So I will keep a viral illness as a topper priority. I'll make salmonellosis very low down because the time period is too short. If it was 3rd week or 4th week, I would have thought about salmonellosis getting complicated into so many things. But I would keep acute viral syndrome with arthralgia, myalgia syndrome as a different possibility in this case.
Yes, sir, absolutely.
Camilla, ma'am, do you have any other thoughts here?
Just to sort of keep salmonella out, what was the CRP, Venkat?
Ma'am, actually, I don't think it was measured, ma'am, because
it wasn't really looking bacterial. Fine, got it. Because we use CRP a lot to sort of quickly differentiate upfront, so fine.
It wasn't said, ma'am. Of course, 2 sets of blood cultures, as in 2 aerobic and 2 anaerobic, were drawn, and patient was started because it's a sepsis syndrome with a septic shock. Ultimately, he was started on broad spectrum antimicrobials.
But it's okay. I said it needs much longer. 2 weeks have to usually elapse by the time they get so sick. And this boy is really sick within the first 4 days, right? This is the 4th day, 5th day by the time he's come to you?
Yeah, this is 5th day. Yes. 8th, his symptoms started, and 11th evening, he was essentially critically ill.
Yeah, so too quick for entry. Fine. Go ahead.
Yeah, I would add here that I think Dr. Venkatesh has rightly pointed out for the postgraduates that if such a situation comes to your ER, he should be covered with a broad spectrum antibiotic at this point of time, because you are having a multi-systemic involvement. Patient is in shock. Although we are keeping viral as a very high possibility, but it is prudent that we cover them with gram-positive as well as a gram-negative cover till we defervicize them, and then we can proceed once we get some contributory events.
Venkat, you can proceed with your other slides.
Yeah. So, I mean, I've not put that as a comment, but clinically there was no rash or eschar on examination. We had looked, everywhere. So the troponin, the CRP was measured. It was later actually, 53.7. The troponin was elevated at 170. Our cutoff is less than 26. And now the other important clues are evidence of coagulopathy. That is, the APTT as well as INR are elevated. So some kind of a DIC-like picture. And as you can see, there is, severe shock. AST has gone up to 453. CPK is again high. And I think there is a component of ischemic hepatitis that is creeping in. So as the labs were repeated, these were the things that were evident. And again, as the patient continued to be evaluated, one sees a severe drop in hemoglobin of 5.7. White cell count is 4,900. Thrombocytopenia, INR is 7.3. APTT is 105. Bicarb has come down to 9. Creatinine has gone up to 3.89. And the EEG actually had shown isoelectric activity consistent with electrocerebral silence. Drug panel, I think he was sedated and so on. And then, as the events progressed, he continued to very, very unfortunately deteriorate with severe acidosis. Started to have, the next day, the day after he got admitted, bleeding from the mouth and the Riles tube. No improvement in the hemodynamic status. We had started him on renal replacement therapy with a cytosorb filter, but even with that, there was no improvement. So essentially, I'll just run through the other labs that were done.
Dr. Venkatesh, can I stop you here for a minute?
Absolutely. Yes.
Yeah. His CRP was very high, and he had 6% band forms on peripheral smear.
Right.
Will you still keep a possibility of a bacterial endotoxic shock, or you will not keep it as a possibility?
I'll keep it a little bit low, sir. This kind of, I mean, if you see the clinical syndrome is kind of consistent with viral hemorrhagic fever.
I agree with you 100%. But I mean, my point is that whether a secondary infection or a per se as a gram-negative sepsis should always be considered.
Absolutely, sir. Absolutely. Yes. So in a critically ill patient, it is, it is very important that we cover with gram-negative and even perhaps gram-positive organisms. Yeah. And rickettsial also. But yes. So we again repeated the dengue NS1. Perhaps the first sample was drawn very early. That was negative. Scrub typhus antibody was negative. Procalcitonin was 19.21. LDH was 14,740. Screening for bloodborne viruses was negative. D-dimer was 1.05 lakh. Okay. Elevated FDP, platelets 20,000. INR 5.1. Again, APTT is elevated. Repeated the smear and antigen again. That was also negative. And anyway, the clinical suspicion of these were low, but they were already, I think they were sent off by some other physicians. Testing for hepatitis A and E and CMV was negative. So,
can you review the panel with the help of the previous slide? Should we have repeated a NS1 antigen again after 15 days or 20 days of illness?
Camilla ma'am, how do we interpret these tests? Say, for example, IgM in the setting of acute febrile illness, IgM lepto comes positive and IgM scrub comes positive.
Sorry. Most of the antigen tests must be done within the first 5 to 6 days. 6 days. And after that, as soon as by about the 7th day, you can start doing IgM. In AUFI, I don't think there's any role for IgG at this point. We're looking at either an IgM specific to what we are suspecting or an antigen if we are within the first 5 to 6 days. After the 6th day, mostly we shouldn't do any antigen test. And for that matter, even the PCR starts decreasing because it's more or less a representation of the organism. So then after about 6 days, they're just left with serology, and that serology in terms of IgM. Most IgMs today are available in form of rapid testing. So I think we could resort to that. But we found we always confirm our point of care rapid testing with an ELISA. Okay? Yeah.
Thank you. Dr. Bhargava, what is the role of empiric antibiotic therapy in acute undifferentiated febrile illness?
Yeah, so we would assess, as Dr. Kaul suggested, that we should triage the patients for any red flag features suggestive of, severe infection. And if you have a person in the first week presenting with a multi-organ dysfunction like this, unlike enteric, which really progresses in the second or third week, we have in India scrub typhus and leptospirosis among the bacterial infections, which can very rapidly progress to multi-organ dysfunction within the first week itself. And therefore, that is the commonest thing in undifferentiated fevers, where we should initiate appropriate antibiotic therapy to cover for both of them. And in that case, it is very, very rational to do this, because every single day in delay can, make a difference to the mortality rates here. So we should not wait for the scrub IgM or lepto IgM, which in any case will be misleading, and initiate therapy with, say, one commonly used combination is ceftriaxone with either doxycycline or azithromycin, which will cover both these pathogens, apart from other pathogens like enteric fever also. But if you have setting for a localized infection, like it has started only as a pneumonia progressing to septic shock, then depending on the organ involved, then you can, and the common organism that you need to cover, then you can initiate therapy for that. But to bear in mind that in empiric therapy, beta-lactams and quinolones will not cover scrub typhus. So it's important to understand that scrub typhus will only respond to tetracyclines or azithromycin, and not these commonly used agents. Even if you use meropenem, it will not going to affect the scrub. So that was my thing for empiric therapy. Thank you.
Okay, thank you. Venkat, you can proceed and show the final diagnosis, what you achieved in this.
So the boy unfortunately expired within about a little more than 36 hours after hospitalization. With the cause of death was labeled as septic shock with DIC with acute renal failure, possible viral hemorrhagic fever. And the chikungunya PCR was actually positive. Dengue virus RNA PCR was negative. Dengue IgM was also negative, which was done on the night that he had, on 13th of July, the day he had expired. I'll just take 30 seconds and just talk a little bit about chikungunya, which is an arthropod-borne alpha virus transmitted by mosquitoes. So traditionally, it doesn't come under viral hemorrhagic fever, because under that you have the flaviviruses, of which chikungunya is not a part, filoviruses such as Ebola and Marburg, and the order Bunyavirales, so the arena viruses, Peribunia viridae, and then so on. Nairo, Hanta, Crimean Congo hemorrhagic fever.
Venkat, we'll have to make it fast.
Yes, ma'am. So anyway, I will just say that it's actually, if you see the chikungunya, it's transmitted by the Aedes albopictus mosquito, and you can see that it is, the distribution is more or less worldwide, including there are certain hotspots in America. It can present as an acute infection. Very rarely you can have severe complications, as in this case. Can present with chronic arthritis and arthralgia, and there's also a syndrome of neonatal infection. As Camilla ma'am has mentioned, we don't have an antigen for this, but RT-PCR in the first 5 days, excellent sensitivity and specificity, and following about on average 5 days, you can use a serology. So management again depends on the stage of the disease, whether it's an acute or a post-disease acute arthritis or a chronic arthritis, and prevention is with mosquito control, and there is some scope for vaccine development also. Thank you.
Yeah, thank you, Venkat, for that case presentation, and Dr. Ajas, thank you and Dr. Camilla ma'am for discussing this case. We will move on to the second case, which is by Dr. Harsha from KMC Manipal, and Dr. Anurag Bhargava will be discussing this case. Dr. Harsha.
In the interest of time, Dr. Kavita, should we have him present the case fully rather than stop in way?
Yeah, we'll stop once in between.
Okay.
Yeah, your screen is visible, Dr. Harsha.
Proceed.
We are not able to hear you, Dr. Harsha.
Good evening, everyone.
Yeah.
So I thank the SIDS and Tropical Infection Subcommittee for giving me this opportunity. So we are, my presentation is.
Just go to the next slide.
Just try to right click and maybe go and click on next.
Chef, it's not moving. Stop sharing and open it and then start.
No, stop here. Stop here.
Stop share.
Shall we go to the...
Here.
We'll proceed to another case till the time he sets up the...
you can present this way.
Is it, it's working. Sorry for the delay.
Make it quick.
Stop.
Yeah, we can see the next slide.
Yeah, the case is about 56-year male farmer from Sagar village, Shimoga district, Karnataka, without any comorbidities. He's non-alcoholic and non-smoker. Complaints of fever since 7 days, continuous, moderate grade, no chills and rigors, malaria since 5 days, bilateral legs, thighs, and arms. 1 episode of vomiting on day 1 of fever, transient headache along with fever. On examination, vitals were normal. A blanching rash was present on the back and trunk. Bilateral conjunctival suffusion was present. Systemic examination was normal. So this is the picture of the patient with the blanching rash over the entire back. These are the baseline investigations on day 1 of hospitalization. So mild thrombocytopenia, mild leukopenia, bilirubin is elevated, AST is elevated more than ALT, CRP was normal, 2.6, CPK, since he's having malaria, CPK was done, which was also elevated. INR was normal, but PTT was mildly elevated. Day 1 of X-ray was showing some infiltrates in the right lower zone. So day 4, patient develops tremulousness of limbs, jaws, involuntary movements of eyes. He had 1 episode of seizure in hospital. Post-seizure, his GCS was E3, V2, M4. Some neck stiffness was present. Immediately a CT scan was done. Nothing significant in the CT scan. Dengue, NS1, IgM was negative. Malaria was negative. Blood cultures was sterile. These are the following investigations, day 3 and day 6. The thrombocytopenia was there. WBC are lower side. Bilirubin, AST, ALT are sequentially elevated. CPK is sequentially elevated. He has gone into AKI. This is a X-ray. Within 4 days, there was bilateral lower zone infiltrates.
I think you'll have to go back to the slide which shows the coagulation abnormalities. Yes, this one.
APTT is sequentially elevated, and platelets were around 96,000, 80,000, and 81,000. APTT was sequentially elevated. INR was almost normal. This is a syndromic diagnosis: myositis, hepatitis, meningoencephalitis, ARDS, AKI, leukopenia, thrombocytopenia with prolonged APTT.
Dr. Bhargava, how would you approach this acute febrile illness case?
Yeah, so very interesting situation here. And we have formulated an approach to AUFIs in our clinical practice article in BMJ 2018. And I would follow the same steps that we have elaborated there. First is the epidemiology of the illness here. Epidemiology means at what time of the year is the patient presenting, where is he located, and what is anything specific about this person in terms of exposure to risk factors or risk factors as such. So if you see this patient, many of the AUFIs are always in the rainy season or post-rainy season. So it's malaria, dengue, chikungunya, and even leptospirosis and scrub. They are usually from July onwards to sometimes in November, December. But this patient has presented with an AUFI in April. If I'm not wrong, it was April. And that is a drier season in India, including, I don't know whether in Shimoga they have rains at that time, but I don't think so. So this is not very typical of the usual pathogens that we're talking about. When we talk of a farmer, then they are having some risk factors. For example, they'll be walking barefoot on the grass, getting exposed to scrub. The rice fields may expose them to, leptospira. They are in contact with livestock who may be infected, with ticks, etc. So there are multiple exposures in any farmer, which, can be relevant here. And according to this, there is no other comorbid condition which will predispose him to any particular AUFI. So some of this AUFI has now actually progressed to so first step is epidemiology and lastly, the place distribution. He's coming from Shimoga in Karnataka, which has been associated in the past with a particular, arboviral disease. We'll see if, there is anything related to that. And then the next slides, can I just see the slide again? So the next slide. Now the second step is the clinical features. And the clinical features here are that undifferentiated fever, myalgia, headache syndrome, but it is now progressing to real encephalitis. There is mild jaundice, which is, can I see the slides again? Harsha, it might be useful.
Yes, sir, yes.
You have again trouble. But anyway, what we see in the basic investigation, the clinical features, you have not mentioned any SCAR or not. You mentioned conjunctival.
There was no SCAR, sir.
So conjunctival suffusion can be there in many infections, including leptospirosis. They can be there in scrub also and in other arboviruses. So that is not very specific. You did not mention any muscle tenderness, which I would be looking for in this patient.
Muscle tenderness was there, sir.
Sorry?
Muscle tenderness was there.
Okay. And now very clearly there is a rash. Now, sometimes again, rash may not be very specific to any illness unless, of course, if there is a particular type of rash, like, for example, an ulcer like in this thing. But rash will exclude certain other diseases. So, for example, blanching rash here excludes malaria and excludes enteric fever. We don't see this kind of rash. So, findings are not only suggestive of sometimes some infection, but they can rule out. So, immediately I would say that the malaria and this thing is not important. He already has some respiratory involvement here. So multi-organ involvement, and it is often common not to see any respiratory signs, but have hypoxia. Can you take the next slide here? Now, this is very critical here that in this patient, given the fact that he presented with fever and rash, okay, although it's not in the rainy season, still we would consider a dengue illness, but he's showing relatively mild thrombocytopenia and leukopenia, both which can occur in dengue. But he has some features here which are against dengue. So commonly, jaundice is not a feature of dengue, but in terms of probability. So the fact that he has bilirubin 2.5 is less common in dengue than in other conditions like leptospirosis or scrub typhus. But critically here, we see that the CRP is normal. And where you have there is an overlap between, so you may consider dengue and leptospirosis. Both can involve, muscle ache, etc. But in leptospirosis, usually the CRP will be elevated, and this has been documented in the literature that in the leptospirosis CRP will be elevated. Usually you have a normal count or leukocytosis. But in this patient, there is leukopenia, which is going against leptospirosis. So you have a situation which is probably a viral fever, but not exactly looking like dengue here. And although he has multi-system involvement, including probably renal and including hematological DIC, it is not looking like lepto either. So that was my conclusion here. And in the subsequent slides, you have the bilateral involvement with as you said, the opacities have progressed. Next. And you have the peculiar thing that there is coagulation abnormality, which is limited to APTT prolongation. So usually in DIC, you would have thrombocytopenia along with both PT and APTT elevation. So that is a little unusual, but isolated involvement of the prolongation of APTT would be consistent with the involvement of the intrinsic pathway and the common pathway. So you have to look at some abnormalities which may be affecting selectively factor 8 or 9, and some of these have been described in conditions.
So, with the CRP normal, would you also rule out the scrub typhus?
Yes, generally bacterial infections, there is not a lot of literature there, but definitely it has been looked in lepto, and lepto CRP is usually elevated. So again, as I said, the seasonality is a very important thing here. In April, in the dry season, we would not suspect scrub. Given the fact that, okay, I can bring it here. Shimoga was the first district to have another, less common arboviral illness described in the 1950s, which is KFD. And that is typically seen between January and May.
Yeah.
So I would put a lot of importance in the seasonality here also.
Sure. Harsha, why don't you proceed?
Yes, ma'am. So these are the investigations. APTT is prolonged. Patient had flapping tremors. Ammonia is increased from 72 to 130 next day. Clinical diagnosis of hepatic encephalopathy. Anti-hepatic encephalopathy measures were started. Day 5, he had shock. He had bleed in NG aspirate, hematochezia, shock, purpura fulminans, DIC, low fibrinogen, pancreatitis, AKI, ARDS requiring mechanical ventilation.
Yeah, so what are the other investigations?
Dengue and leptospira came negative.
Can you show in full screen, please? Can you show in full screen, please? Thank you.
Yes, sir. Leptospira and scrub came negative, sir. FD PCR came positive.
Continue, Harsha.
So, as you told, sir, that's 1957, the first case of KFD was reported, notified from Kesnur village, from Shimoga district. Basically, that year, similarly, they've notified many monkey deaths in the same year, black-faced langurs and red-faced monkeys, followed by a first young boy who climbed a tree to fetch some honey, but finally it was not honey, it was some dead monkey body which he was touching, and some tick bite he had, and he's the first case reported. So this is seen along the Western Ghats, particularly Karnataka and Kerala. These are the clinical features of KFD: fever, chills and headache, severe muscle pain, vomitings, bleeding problems, conjunctival suffusion, and some papular eruptions or the soft palate also can be seen. And it is a biphasic illness where 10 to 20% of patients experience second wave of symptoms at the beginning of third week. In the second phase, symptoms include fever and signs of neurological manifestations such as severe headache, mental disturbances, tremors, and vision deficits. Diagnosis in the first 5 days, it is by PCR. After 5 days, we can still use PCR, and IgM. Take-home message is, as already sir was discussing, a place from where the patient is coming, his occupation, exposure, and the seasonality, because this fever is seen in the dry season, particularly December to May, where the villagers go to the adjacent forest to procure their firewood, to graze their cattle. This is a season where they visit forests and acquire this disease. So KFD is also one of the cause of viral hemorrhagic fever. Thank you.
Thank you, Harsha. Dr. Bhargav, what is the threat of hemorrhagic fevers in India? So
I just wanted to say this. Thank you so much for this excellent case, which really stimulated thinking. So hemorrhagic fevers normally, before I talk of hemorrhagic fever, I just would like to say this one thing, that Oscar has said that medicine is the science of uncertainty and the art of probability. So when we are talking of these watertight compartments of different syndromes, not only is there an overlap between diseases, but one disease can present with many kinds of syndromes. For example, this patient probably did not present as a classical hemorrhagic fever to begin with, but ultimately he had a coagulopathy. So amongst the hemorrhagic fevers in India, we classically are talking of dengue and, for example, other arboviruses like KFD. But as we saw, there could be chikungunya also progressing to hemorrhagic fever. But there are some other things like Crimean Congo hemorrhagic fever, which needs to be looked out because it has been described post 2010 from Gujarat and then Rajasthan. And most importantly, the first case was actually reported in a nurse who had handled a patient who died of Crimean Congo hemorrhagic fever. So again, it's a tick-borne arbovirus, which has been reported, and serological investigations have shown that a lot of the livestock in India are, exposed to this virus, and they remain subclinical. Here, of course, we do not know whether this patient had any, epidemiologically, there was any history in this area of monkeys dying, but monkeys dying can be one of the kind of early signs that, KFD may be striking in that region. But Crimean Congo, I would try to particularly this thing. And Ebola, of course, we have no reports of indigenous Ebola, but Crimean Congo has the same potential for fatality as well as transmission. So
what about yellow fever? Because there is a risk of spread of yellow fever because the vector is very much prevalent in India.
Yeah, so but our Aedes aegypti, I think, prefer dengue rather than yellow fever. I don't know what is the reason. But, the yellow fever is not seen. If anybody else has any idea, but yeah. Again, in this, I have not personally actually seen KFD. Really, we suspected it in a few patients, but I must congratulate Manipal for actually KMC for bringing out this series. And in fact, somebody in our department, a senior professor, Dr. Prabhadikari, reported the first, large case series also. And I enjoyed reading those articles also. But Dr. Kavita, would you like to say something on your own experience with KFD here to enlighten the audience?
Yeah, so the KFD we see, as I said, in dry season, and it's one of the biphasic illness in about 5 to 10% of patients. And the first phase generally has hemorrhagic manifestations and myositis and hepatitis with thrombocytopenia and leukopenia in first phase. And second phase, it's more like aseptic meningitis, which can occur about after 1 to 2 weeks of the primary illness in about 5 to 10% of the patients, which is mild and self-limiting. But most of the mortality happens in the first phase of illness because of liver failure, encephalopathy, or encephalitis. So the overall mortality is about 5 to 10% because of myocarditis, hepatopathy, and encephalitis in the first phase. Second phase, generally people recover. It's supportive. There is a vaccine, which is a formalin kill vaccine, but generally ineffective, requires a lot of funding and a lot of work to do in KFD. I think for want of time, we'll move on. Thank you very much.
Kavita, can I make a small comment on hemorrhagic fevers?
Yes, sir. Please.
Yeah. We have discussed very important cause of hemorrhagic fever, but we must forget falciparum malaria can cause hemorrhage with disseminated intravascular coagulation. In fact, recently we had a patient, 3 days ago, we lost a patient. And also we should remember meningococcus. Meningococcus can also present with hemorrhagic fever. So apart from the important ones we have discussed, we need to keep falciparum malaria as well as meningococcus as causes of hemorrhagic fever. Thank you.
Yes, sir. Thank you. Let us move on to the third case. Harsha, you can unshare. And Dr. Zubair Nazar from SKIMS, I request him to present the case, and Dr. Bibhuti Saha will be discussing. Dr. Zubair. So we have just seen the the hemorrhagic manifestations in KFD, a rare disease, which we have to be vigilant. It may spread to different areas, adjacent areas especially. And when we come across very unusual cases, we will have to dig deep and try and send some investigations where to the reference laboratories. Not all investigations will be present everywhere. We will have to search where the reference laboratories are. Viral diagnostic laboratories are set up throughout the country, and we may be able to send the samples to those. Zubair, are you able to share your screen?
Ma'am, I have been, my video has been stopped by the host. I am not able to share my video.
Ruth, can you enable him? Zubair Ahmad.
Hello, ma'am.
Yes.
Doctor, 1 second, I'm doing it.
My video has been stopped by the host.
1 second.
Okay, ma'am.
If he has problem, can we go to Dr. Muhammad Niaz, who can present his case, and Dr. Swati Rajgopal can discuss this case. Dr. Niaz. Yes, your screen is visible, Niaz.
Is it visible? Okay.
Yeah.
So I'll present this case, a pregnant female with fever and pruritic rash. So this patient came from Trivandrum, south of Kerala. She's a housewife. She's pregnant and 38 weeks of gestation, who had an eventful pregnancy till now and presented with a fever and rash. So her symptoms started 6 days prior to the presentation to a hospital. It was associated with fever, which was mild and lasted only for a day without bothering her much. 2 days later, she noticed a rash over her face, which was spreading to her chest and the upper limb, which was a macular-papular rash. It was mildly pruritic. So this is a rash. I don't know if it is quite visible. It's a very faint kind of rash, and predominantly in the upper limb as well as the face and the trunk. It was pruritic. Characteristically, it was pruritic. 2 days after the onset of rash, she noticed redness of the eye. There was no pain in the eye, there was no diminution of vision, or there was no discharge. Also on the same day, the patient had pain in the small joints of the hand with mild swelling of the joints. History of similar undiagnosed exanthematous fevers was reported in the community in the preceding few months. So this is the eye picture. You can see the redness in the eye. There was any discharge. There was no visual disturbances. So this is the presentation of my case. She presented with mild fever. She had a rash which started 2 days later, which was pruritic. And there was redness in the eye, which was also associated with pain in the small joint of the hand. I'll also show the basic labs before I go to the discussion. So examination, I have already told you about the rash, the conjunctival erythema, as well as the rest of the physical examination were with the normal limits. And she was hemodynamically stable. So the investigation showed a normal leukocyte count, lymphocyte count is normal count, hemoglobin was normal, there was no thrombocytopenia, the CRP was 7, there was no transaminitis, and the rest of the investigations also were normal. So at this point, what are the possibilities that we can think of this patient presenting with a kind of a mild fever, mild symptoms, and a rash which was pruritic, conjunctivitis, and arthralgia?
Thanks, Dr. Niaz, for the case. So I'll be a little cheeky because I know from which place you come from. So obviously, when you come to Kerala, you think of all exotic things and what comes in first. But I think from what I understand, this lady does not have any history of travel, right?
Yes, like she's from Kerala, like there is no history of.
Yeah. So I think in some, from what I would understand, it's a person who is obviously you're looking at a pregnant lady at 38 weeks and basically has presented with a viral rash. And obviously, it's not toxic looking. But what's most important to understand are very important things that you sort of classically mentioned, that it's a mild low-grade fever, which is in contrast to a lot of other febrile illnesses where we have like dengue or malaria or chikungunya, where the fevers are quite high grade. So I think the first thing that I would look at it is, yes, it is the day 6 of the febrile illness, a non-toxic looking person. It's a non-purulent conjunctivitis, and obviously people who have a rash, which obviously it's not a classical rash, but definitely it's a rash that you need to keep in mind if you're a person who looks at other viral fevers. Yes, you could have thought of rubella, measles, etc., because it's a pregnant lady. But looking at the fact that she's not otherwise sick with a normal looking numbers, the differentials, obviously, if I have to look at it traditionally, you look at all arboviral infections is what I would look at this stage.
Okay. So I'll also show the initial investigations, like virological investigations that we did. So IgM dengue was negative. Rubella, measles was also considered, considering the maculopapular rash this patient was having. Chikungunya IgM was negative, chikungunya RT-PCR was negative, and COVID-19 was also negative. So these are the basic labs that we initially did.
Okay. So I think it's important for a learning point that you've done investigations at the right phase of the illness, because it's around day 6, day 7, and most of these you're pretty much excluded right up to COVID-19. But what's important is the things that we would basically look as one which is basically non-toxic are things like Zika, because considering the fact in that particular area where you pretty much saw more cases than most of us. So as I said in the start itself, I'm being a little cheeky because I know where you come from. But I think in a pregnant lady, what's very important besides measles, rubella, that most of us started looking in 2019-20 is pretty much to look at Zika as one of your differentials, because the person is not very sick.
Yes, so that's what we also thought this time. So the real-time PCR for Zika virus was positive in serum, and this lady, in fact, was the first diagnosed case of Zika virus disease in Kerala. First diagnosed case because we have been seeing a large number of cases previously in Kerala with the similar symptoms, and we have been sending Zika PCRs also for these patients. But since maybe the viremia of Zika is very limited for a limited period only, most of our tests in fact came negative. In fact, many of our healthcare workers had a cluster of similar symptoms, and we had sent the investigations to NIV, and the initial investigations all came negative. So the point in Zika is that the viremia is transient, and in serum testing often we can get negative testing.
I guess most of them have done well, right, Dr. Niyas? Yes. I don't think there's not been anything really bad about Zika, apart from all the complications it could potentially have. But from your case records, especially most of our data comes from Kerala, if you look at it, I think the good part about it, it's sort of, most of them are self-limiting in most cases that we have sort of reported.
Yes, all the cases that we have seen are self-limited. Most of none of them had much of a it was a mild fever associated with the pleuritic rash. The only thing is that at that particular point of time, we have seen a cluster of severe myositis, some of them even leading to mortality. And in one of these patients, the urine Zika PCR was positive. We are not very sure we can link this myositis to this. And we had done serology in some of these patients also. And the serology for Zika was also positive, even the BRNT test. So a possibility of a myositis linked to Zika is that is something that has been not reported, but we don't have it definitely. So that is the only complication perhaps that we could see. Otherwise, most of these patients who presented with a typical presentation of Zika were mild, and we were also worried about the the pregnancy complication. But we have many pregnant females also. And in fact, some of them, in fact, went for termination of pregnancy, but we did not see much of an adverse pregnancy outcome or any increase in microcephaly or congenital malformation in the area, even after
like you say, the tricky part in most Zika is that people have not validated in terms of the malformations, in terms of each trimester of pregnancy. So, I mean, though we have well-defined microcephaly, etc., the percentage in each of them seems to be a little varied. So maybe we got a little lucky, probably in this lady to get away with not much of complications. So probably maybe early pregnancy or at conception.
Yes, ma'am. Even in females in early pregnancy who have been affected, we had a few cases, but we did not see much of an adverse events. Maybe because this was the sequencing of this particular virus was that in Kerala was done. It was Asian lineage, which is not associated with much of a neurological or congenital complications.
Makes sense.
So this is just a map of the area. We had the cases from after the diagnosis of the first case, about more than 80 cases has been diagnosed in Kerala. But the outbreak has been controlled as of now. You don't see any new cases at this particular point of time. So that is from my side. So basically, Zika disease. The thing is that you have to suspect sometimes diseases that are not quite common in your place, or exotic disease also can present for the first time, and we have to keep a high index of suspicion. And Zika, the PCRs sometimes can be negative, especially in serum. In urine, it can persist for a long time. And if you have a clinical suspicion which is strong, you have to do a serological test, which can be an initial ELISA, which can be confirmed by a peer-entity test for Zika virus.
And Dr. Nias, Dr. Anurag has a nice cheeky question there about Kerala and its incidence in a lot of infections. I think Bangalore and Kerala, in terms of topography and epidemiologically and the tropical nature, I think it attracts a lot of these infections. I think we get to learn a lot more from these places as far as tropical diseases are concerned.
Thank you,
and
Nias.
the connection between the forest as well as the close proximity of humans also. You can have a slight migration of organisms between the two places.
Thank you,
Forest
Swati.
also maybe that it is very connected. Kerala get people from everywhere. I mean, about people go everywhere and throughout the world and come back. So that may be another reason.
Yeah.
Thank you, Nias and Dr. Swati. I would like to ask a question to Dr. Camilla, ma'am. Interpretation of this IgM for Zika, it could cross-react with the dengue. Or so, what do you want to say about this caution?
Problem with most IgMs is whether it's lepto IgM, whether it is dengue IgM, whether it is Zika, they all tend to give a cross-reactivity with the flaviviruses. In fact, we've had a case of West Nile that was actually, it came positive, but the patient also was showing an NS1 antigen. So there's a lot of cross-reactivity we see, especially with the flaviviruses. And Leptospira IgM tends to also cross-react with the outer membrane protein with some enteric as well. So the problem with serology is it must be confirmed ideally with nucleic acid test, but we've lost the time, you know. So by the time serology comes, the nucleic acid, the PCRs come negative. So that's an issue we need to maintain. So keep serum, keep something which we can go back if serology comes positive, just to be sure. But usually the clinical picture is kind of evident by that time. So, but there is definite cross-reactivity in flaviviruses, whether it's JE, whether it's West Nile, whether it is dengue, they tend to cross-react with lepto, with dengue, and with Zika.
There's a question from Vikasuri. What is the interpretation? What is the interpretation if more than one IgM serology is positive in a patient with undifferentiated febrile illness? How do we resolve?
See, IgM generally remains positive from about 8 days to about 3 months. So if the poor chap is sitting in an endemic zone, I mean, he may have an overlap, he may have had dengue and actually get another infection subsequently. So 3 months IgM tends to be positive. We just have to live with that.
So is it useful to show a fourfold rise in IgG?
See, IgG I really don't believe for, especially for AUFI, it really has no role. But if it goes on beyond 2 weeks, yes, you can do, and you can do avidity testing for IgG, where avidity testing, the more avid it is, the, you know, the tighter it binds, the better the antibody. So avidity testing is actually used for more chronic infections, not so much for IgG antibody.
So there is many times it is very difficult to establish what exactly is the cause of undifferentiated febrile illness. And according to the series, it's almost about 40 to 50% in some of the places. It's very difficult to exactly pinpoint what the diagnosis is.
Absolutely, because especially with Aedes being such a common vector for so many endemic diseases in the tropics, it becomes difficult, especially with dengue complicating the picture.
Dr. Bhargava has something to say.
Yeah, if I may just add to this, first of all, regarding the Zika, just for the sharing of learning, compared to dengue, conjunctival involvement is more common in Zika than other arboviruses. And also, as he pointed out, the rash is more pruritic. So pruritic rash again is more seen with Zika, I believe, than other arboviral infections. Of course, in the recovery phase of dengue, also we get a pruritic rash. So that was one thing. And this question about multiple serologies being positive, I would just add here that the only way you can use an IgM for the confirmation of diagnosis as initially, if the IgM has been negative and you show seroconversion, so another IgM done 7 to 10 days later turns out positive, only then you can be certain that this IgM indicates, very recent infection is correlated with the disease. Otherwise, as you said, madam, the IgM elevation after an exposure to dengue can persist beyond even 6 months. And even in scrub, they have shown long-lasting IgM, titers. Lastly, in some cases where the common exposure is there, you can have a true co-infection with 2 organisms. And this has been particularly seen with scrub and leptospirosis. That you have, confirmed overlap between scrub and lepto because the exposure is really the same kind of situation. So many of the time, but however, we are misinterpreting these things. So in the first week, IgM may be negative, and negative IgM doesn't rule out the diagnosis, and a IgM present may not really confirm the diagnosis unless we integrate, observe these caveats.
So, Thank
you. Can we move on to the third case, Dr. Zubair?
Kavita, can I ask a question to Niaz?
Yes, sir.
Kavita, can I ask a question to Dr.
Yes,
Niaz?
sir. Yes, sir.
Niaz, are you here?
Yes, sir. Yes, sir.
Okay. I have a question to you. In the areas you're seeing Zika, what has happened to dengue? Is it still there or it has disappeared? Zika has displaced dengue. How is the situation?
No, sir. Like Zika outbreak, the outbreak was there in 2021. We saw like around 100 cases in Trivandrum district, and it went away. Like we are not seeing the cases again. Like dengue has come back. Dengue is still there. We are still getting dengue cases. So Zika is like we are not seeing any cases of Zika after that outbreak. It just came as a outbreak, and it went away within like 3 months, and then we still have dengue. So not many dengue cases, no Zika.
Okay.
So the important thing is to also be aware of the outbreaks, the epidemiology, what's happening around. The infectious disease specialists or the people who are managing undifferentiated febrile illness have to be aware of what's happening around. Definitely, the spotting the index case is very difficult and it's challenging. So I just have one question. When we do not know what the illness is, so how is the first index case identified? Ma'am, Camilla, ma'am?
Tough call. That's really a tough call. I think we rely on great institutions like yours to sort of say that this is a problem, but clinically sometimes, you can, like, from a microbiology perspective, the minute he said Shimoga, I only thought KFD, everything else melted off, So it's kind of from a lot of epidemiology, but new infections, I think we need to rely on PCRs. That's the only way to go.
Is it for pathogen discovery? Is it like sequencing that we may have to do, for example?
Look at SARS. Within 4 days of the virus being actually described and the serum being, and the nasopharyngeal material, they got the sequencing. 4 days. I mean, how wonderful is that?
Yeah.
So clearly, it has to be, it's molecular that's going to tell you where we are going, especially for new infections.
So we will all have to remember that if there is a, outbreak which is unidentified yet, definitely we will have to collect as many samples and from different samples and send it to the reference laboratories, and they will only have to discover the pathogens. And subsequently, we may be able to develop the immunoassays or antigen-based tests. So we have to keep our options open. I would like to move on with Dr. Zubair's case. Will you be able to share your...
Hello, ma'am.
Hello?
Ma'am.
Yes.
Respected panelists, I have some difficulty in sharing, but I would like to use my camera to share it. Are you comfortable like this?
Yes.
Is it visible?
Yes.
Huh?
Should I try once, Zubair? Let me try.
Okay, ma'am.
Is it visible?
Not yet.
Not yet.
Yeah, now.
Yeah, now it's visible.
Zubair, you can present.
Yes, ma'am. Thank you. Can you just enlarge it? Thank you, ma'am. Respected panelists, dear audience, coming to our case, Next slide, please. Our patient was a 42-year-old female with underlying primary hypothyroidism. She had returned to Kashmir from Delhi. After staying there for 1 month, she developed fever 2 days after return. Fever was continuous type, high grade, no diurnal variation, associated with chills, rigors, and sweating. No localizing symptoms were present. Next slide. Other than tachycardia and tachypnea on examination, there was no localizing sign and systemic examination was unremarkable. However, fever was slightly relieved by antibiotics. Now coming to the investigation part, CBC was revealing bicytopenia, a mild leukopenia, mild neutropenia, and mild thrombocytopenia with dropping ANC. However, there was increase in acute phase reactants. Next slide. Increase in acute phase reactants, both ASR and CRP were elevated, with UAG showing mild hepatosplenomegaly. Routine urine examination and cultures, including both blood and urine, were sterile. And other baseline investigation, including KFT and LFT, were normal. There was no clue on those investigations. Malaria car test, including rapid diagnostic tests as well as BBF, were negative. Dengue, NS1 antigen, serology, both were negative. Leptospira serology, IgM, ELISA, and rickettsial serology or scrub types were negative. Patient was negative for having negative PCR for both SARS-CoV-2 as well as influenza. Next slide. So coming to this case, earlier my colleagues presented cases with critical illness, undifferentiated fevers with critical illness. This is a case we have an acute febrile illness, undifferentiated. As of now, we have no clinical clue as well as any lab clue. So we want.
May I request Dr. Vibhuti sir to give your thoughts?
Yeah. Thank you, Dr. Jubair, for presenting interesting case. And as we see, the patient had been at Delhi, this 45-year-old lady, a 42-year-old lady with hypothyroidism. She had been at Delhi for 1 month, and then after returning to Kashmir, after 2 days, she starts having a fever.
Yes, sir.
So obviously, this is something she has possibly acquired by staying at Delhi. And as you said, there are no localizing signs or symptoms. And when you examine, you find there is a leukopenia and a mild thrombocytopenia. And can you show the next slide, please, also? Yeah. And we can see the ESR and CRP are a little raised, and USG abdomen and pelvis are showing mild hepatosplenomegaly. So at this point of time, and your VDL is negative, and all the other tests, as you said, are negative. So at this point of time, you are getting a lady, 42-year-old lady with a recent history of travel to Delhi, and presented with fever, with chills and rigors, sweating, and no localizing signs and symptoms, and investigations showing leukopenia and mild thrombocytopenia, and other specific tests, as has been done till now, are negative. So to keep in mind, to go to the syndrome, the fever was for 2 days. She is being evaluated on the day 2 of fever. So you thought of, rightly so you have thought of viral fevers, because those are common in Delhi, like dengue, of course, chikungunya, and all these things can happen. And enteric fever, yes, that's a right possibility, because there's a fever with leukopenia and thrombocytopenia. You have not mentioned any GI symptoms. And of course, malaria, you can always miss the same on a first blood test. So you have to repeat the blood test. So at this point of time, what the points you have thought are right. So I think you go ahead with the next slides here. Yeah, carry on.
Patient was started on ceftriaxone injection with this intention to cover enteric, hoping viral infection will settle off its own, as there was no target organ damage, to give other supportive measures other than paracetamol. Patient's fever pattern started changing with this treatment, from continuous pattern to remittent pattern, and spikes started coming down from 104 to 101. However, patient continued to be febrile even after 9 days of treatment, 11 days from onset of symptoms, and ANC was decreasing. At this point of time, back to the previous. At this point of time, we thought 3 things. Either we are dealing with a viral infection that is settling off its own. Second, an organism that is partially being covered by ceftriaxone, or another bug that is maybe resistant to ceftriaxone, that is why it is not responding. This scenario prompted us to extend our workup for AFI. Next slide, please. Baseline investigations repeated. ANC was decreasing. Blood and urine cultures again sterile. Vidal was not showing any significant rise in titers. Echo was done to rule out endocrites. Transthoracic echo was unremarkable. Patient was planned for bone marrow studies. However, patient didn't give consent for the same. And CT was planned to rule out any occult abscess. But patient, then few investigations came positive, for which CT was deferred. So we can discuss this case.
Can you stop Dr. Zubair now? Yeah.
Yes, sir.
So you have rightly that you have started the patient with ceftriaxone, and even after 9 days of ceftriaxone, though the temperature range has decreased, but the fever is still there. And as you have showed that the counts, WC counts, absolute neutrophil count is still decreasing. Cultures have not given you any clue. The Vidal is still negative, and echo, transthoracic echo didn't show any endocarditis. So at this point of time, we need to think what is happening to this lady. Fever now day 11, neutropenia, still now without any localizing signs. And she has a history of travel to Delhi. Of course, you have thought of enteric fever, you are given ceftriaxone, and we know that there is emergence of drug resistance salmonella typhi in India, though it was more in Pakistan, but we have started seeing XDR salmonella typhi also, where it is resistant to ceftriaxone also. So that's one thought, rightly said. And also, though there are no symptoms of joint pain or rash, but a female lady with a progressive fever for 11 days, we need to think of autoimmune disease also. So we need to think of do an ANA test, at least to rule out some sort of that. And also among the infections, viral fevers, we need to, dengue will not last for 11 days. Dengue, chikungunya will not last for 11 days. But if we think of other viral illnesses, though it's not very common in this age, but Epstein-Barr virus can go on with a fever for prolonged fever, where of course you see some lymphadenopathy, sometimes you see some rash and some rise in the liver enzymes, but that comes in a differential diagnosis. And also, we need to take a very sensitive history, because fever without localizing sign, progressive neutropenia. So we need to take a very sensitive history of the sexual behavior of the patient to rule out HIV infection also. That's something very important. And some sort of blood dysphagia, because sometimes they may not be showing in the peripheral blood. So you need to think of a bone marrow examination also. And lastly, though very rare, but you need to think of very unusual infections, less common infections, like in our country, because we get another infection, brucellosis, which also causes a prolonged pyrexia, maybe without a localizing sign, and may show with a progressive neutropenia. So that you also need to keep in mind. So at this point of time, I think we need to keep these things. We may send relevant investigations, counseling and testing for HIV, EBV tests, and where there is a progressive relative lymphocytosis also. So we need to think of EBV also, counseling and testing for HIV, then ANA, blood for ANA, and maybe you should think of testing for brucella also. So these are the things which are coming to my mind. So you please go ahead.
Where you can continue.
Ma'am, next slide, ma'am. Considering our population, we do screen our patients for brucella, because from our past experience, we have seen patients presenting as acute febrile illness, where we have sent already brucella serology that was showing high titers. Now coming to the SARS point, which he rightly highlighted that we should have screened this patient for autoimmune disease, which we did, proved to be negative because she was showing progressive leukopenia, and we have also experience of seeing patients of chronic disease presenting with leukopenia and febrile illnesses. And bone marrow, she was reluctant. We have two things in mind. We will take cultures, as well as we will try to rule out acute leukemia. And HIV was done, that ELISA, that was negative. Considering these high titers, brucella about brucella milli, we made impression of, please next slide. We made impression of non-focal brucellosis, and patient was started on treatment. After starting treatment, patient continued febrile for 3 more days. Then patient started showing deferescence, and leukopenia started improving. Then on follow-up after 2 weeks, next slide, please. After follow-up of 2 weeks, patient was febrile, asymptomatic, and cytopenia improved. Next slide. There are few studies which do concur with our observation that brucella presents as an acute febrile illness. One of those have been done in Egypt and one in our neighborhood. Come next slide. This is a study that has been done in our institute that is showing enteric fever as the most common cause of undifferentiated febrile illness, and we do have seen brucellosis presenting as undifferentiated febrile illness also. But dengue and malaria and rickettsia, these cases have been seen in those patients who have traveled from outside, especially from Himachal, and rickettsial cases have been seen from those areas, and dengue and malaria from Delhi and other parts of India. Next slide, please. This is one of the study of which Professor Ejasar has been part. He has seen rickettsial infections again as presenting as an undifferentiated febrile illness. Next slide. So take-home message is that we should that chronic infections do present as acutely, and brucellosis should be kept as a differential diagnosis of an undifferentiated febrile illness, especially in a community like ours. Thank you.
Dr. Zue, Dr.
Yes,
Zue, you have made a very interesting case, very learning point all of the participants. Just one question that you have reported also that a good percentage of your fever cases have brucellosis. So are you seeing outbreaks of brucellosis, or you are seeing them as sporadic cases? Because in Kashmir the milk consumption yeah. So how are you seeing that?
We do see these patients, especially with musculoskeletal symptoms. We are right now doing a study on spondylodiscites, vis-a-vis considering tuberculosis as an etiology in brucellosis. We do have found brucellosis as a main etiological agent of spondylodiscites in our part of the world, as compared to tuberculosis also. But we have in past also found that brucellosis presents an undifferentiated febrile illness. That is why in our community, if any patient presents with undifferentiated febrile illness, we do screen him for brucellosis serology, and we most of the time rely on serology. Cultures usually come negative because blood cultures, patients don't have that much bacteremia. So we discard, usually at the outset, we don't incubate those cultures for 21 days. By 5 or 7 days, we discard those cultures. Ultimately, the culture reliability is less as compared to serology.
Ma'am, what should be the duration of incubation for brucella for blood culture?
When you have a patient with hepatosplenomegaly who's partially responding to ceftriaxone, the dose of ceftriaxone is actually used to treat brucella, but the dose of ceftriaxone is 2 grams twice a day. So this patient received 2 grams once a day. So that was a slightly less dose, which is why possibly she continued to have fever. The issue here is blood cultures have to be kept for at least 21 days when you're not using automated methods. We grow brucella happily in 7 days. So we have a protocol by which we keep all AUFIs for 9 days in our automated machines, because the automated media is much better. The other point is that, see, the reason why brucella takes long to grow is its doubling time is 2.5 to 3.5 hours compared to E. coli, which is 20 minutes. So it just is a slower organism to grow. So which is why you have to keep your cultures. The old-fashioned cultures are Castaneidas and lysis centrifugation, and now they've been really replaced with automated methods. We found the microathletic to be pretty good to pick it up, and we happily grow it in about 5 to 7 days. But we have an instruction put on that if it's an AUFI, to keep them on for at least 9 days. And one more point is that when you are suspecting brucella, the anti-complementary effect, the antibodies that may be in the patient, in the patient's blood, they actually inhibit the organism. So normally the dilution factor has to be much more. So you have to put 1.5 ml to 1:10 of the media. You have to dilute it out a lot, so to grow the organism, which is why, again, when they're suspecting brucella, we insist we collect 2 bottles and put 3 to 5 ml in 2 bottles, so that all the anti-phagocytic effects are taken away. And the other point is that sometimes in the absolutely frank case of brucella, as it becomes chronic, the cultures really become negative. But in acute, infections, the cultures are very good. And they will, if you had kept this patient in 21 days, you would have grown it, no question. But you have to keep putting it on a solid media and subculturing regularly if you don't have automation. And from the antibody perspective, remember, sometimes you can get a false negative antibodies because the antibody test is usually a SAT test, that is a standard agglutinating test, but they are blocking antibodies. They are antibodies that show a prozone phenomenon, and those are resolved with a Coombs IgG test. So these issues create, or a 2-ME test, which kind of really helps to break down the blocking IgM antibodies. So brucella is a really fascinating case for a microbiologist because keep it on. We keep saying, don't be in a hurry. If you have hepatosplenomegaly, please tell the lab, hang on to the cultures, don't be in a hurry to cure. You will grow it in the acute phase.
Thank you, ma'am. Thank you for that insights. So there has been Venkat, is there any other question from the participants which we need to take?
No, I mean, I don't think there is anything. One question was, I think, about the use of the cytosorb filters.
Yes.
Yeah. I mean, suffice to say, I don't think there is a good randomized control data to recommend the use, and there is no recommendation in the international sepsis guidelines for the use of cytosorb, as far as I know. So, although there are some case reports which suggest a benefit, but that's the data that there is. That's all.
There's a question from Vishal Gupta. He is asking, in the first case, chick PCR was positive. Is it from serum or from CSF?
No, serum. Actually, because of the severe thrombocytopenia, I mean coagulopathy, CSF studies were not performed. So
there is a question from Harsha. He's asking, what were the risk factors for that patient to acquire brucellosis? That's
yes, we Kashmiri people belong to the Muslim majority. We do handle meat, especially during Eid, and we eat a lot of meat. That is why I think maybe a contaminated meat product has been the direct source for the lady. Otherwise, she has been in Delhi. She doesn't had non-veg outside because of religious issues. Then they were saying that they had these milk products, but they never used raw products. In a community like ours, we are exposed to it by directly handling meat, especially at the time of sacrificing animals.
Here, I mean, Kavita, can I add a point?
Yes, sir. Yes, sir.
If you are using meat in a properly stored and then cooked fashion, probably it will not be a risk factor. What is happening in the Kashmiri community, which we have seen in the brucellosis, is that there is a culture of barbecuization being done. Barbecuization means that it is a half-cooked meat. So it is being relished as a very good dish here. So that has one aspect, that the brucellosis among well-offs, it has been seen among veterinarians, it has been seen among farmers, but among the well-off and elite, brucella is coming up here in Kashmir only because probably the usage of barbecued meat is becoming very, very rampant here.
Thank you. There is a question to Camilla ma'am. Neurobrucellosis, which serological test should be done? Which sample is preferable, blood or CSF?
Also, ma'am, Dr. Anurag Bhargav sir wants to speak. So I think one by one we can.
Yeah.
CSF is preferable if you get to it. Yeah.
Anurag sir.
Yeah, I just wanted to add to the discussion on brucellosis, and we have been diagnosing actually a relatively fair number here. So I think the kind of history that we should ask is more, also about whether any contact with an animal, including meat. So we had a recently patient with 4 months of fever. She was otherwise not toxic. And when we asked, she was from a farming community, how many goats had been delivered in the last 6 months? She had been actively burying the placenta. So the goat has delivered and the placenta was being buried with her bare hands. So we need to be sensitive about these exposures also. Sometimes we are only concentrating on milk. But, if you are slaughtering animals, if you're coming in contact, handling, cows, delivery, etc. That is another exposure. And the other thing was, we got a culture positive in an automated system on the third day itself. And the automated systems are giving some other species as brucella. So often it may be reported, unless we are careful about that, the automated system may interpret it as something else. So that was one point I wanted to raise. Yeah.
Anurag, you have to do an oxidase test and a urease test immediately. Those are pathognomic of brucella. So an oxidase positive, urease positive is brucella
yes. Okay. So that you have to communicate with the lab, and with an automated system, you may get even before 7 days.
Correct. Absolutely.
Ma'am, there's a question. Is there any merit in looking at dengue IgG ratio to diagnose secondary dengue and thereby prognosticate better? Question is from Parvinder Chawla.
See, basically for secondary dengue, it is the IgG that's really high. It's not the IgM that we're actually too fussed about. And the IgM actually comes for such a short time that you really don't see, you may miss it completely. So it's the IgG that gives the diagnosis of secondary dengue. Because the patient is getting it with another serotype, infected with another serotype. Yeah.
So there's a merit in sending both IgM and IgG for dengue.
We always send IgM, but if it is secondary dengue and you're suspecting, you must send IgG.
But it is difficult to suspect whether it's primary or secondary.
Patients sometimes will give a history that I did have dengue 2 years back now. Because now people are doing a lot, they're far more into it, and they'll give you a history that I did.
I think we
Kavita, can I make a point here? Can I make a comment here, please?
Sure, sir.
Yeah.
Go ahead.
When you are suspecting dengue and the IgM test has come negative, but you manage like dengue, and what we suggest is, because IgG is not available in the national program for in the government hospitals, you can't go for IgG. So what you do, repeat the IgM test after 5 days, and most of the time it comes positive. So as Madam has rightly pointed out, in secondary dengue, the IgM peaks comes later. And because we don't have facility for doing IgG, so what you do, repeat the IgM test, manage as dengue, and repeat the IgM test after 5 days. Most of the time comes as positive. So that's how.
There was a lot of questions. I have one question to Camilla, ma'am. With a lot of hope, and some people are practicing management of infections at remote setting. What is the role of point of care testing in management of acute febrile illness?
Huge. Because here today we have antigen testing so easily. One thing is certain, that you have to need a good antigen to pick up this test. You can't just go for a card test that is not reliable. For malaria, we have really reached, we have HRP with specific Plasmodium Vivax PLDH. How cool is that? So it's not only a pan-LDH. We've really arrived where antigen tests are concerned. And I think that can easily be deployed in point of care testing. For dengue, we have NS1. For scrub typhus, now you can get an antigen test. I think we have to go the point of care way with antigen testing. And it's rapid, it's easy to do. It's SARS, you look at how we did it for COVID today. My daughter is doing it at home. So she doesn't need a PCR from her mother. So that's the whole problem. So it's good, it's happened, and it's...
do any panelists want to make any last comment?
I wanted to raise, make the panelists aware that many a times the investigations in case of brucellosis make us really helpless. In case of, especially what Zubair was talking about, is the spinal brucellosis. In case of spinal brucellosis, the patient does not usually have a fever. Usually it does not come with neither a AFI nor a chronic fever. Many a times he just comes to us with a backache. And at that time, with only the hope for a diagnosis remains the MRI or imaging. In such situation, Kamala ma'am, can she help us? Because we are many times helpless. We must have seen during last 4 years more than 200 or 250 odd cases of spinal brucellosis, where CSF is normal, bloods are normal, almost most of the tests are normal. Sometime antigenic test, serology may help us, but most of the times we are held up in spinal brucellosis, tuberculosis versus a brucella. So if ma'am can give us a...
Dr. Ejaz, I absolutely agree with you, but I find we're getting better ELISA tests now. We're moving away from the SAT test and Coombs test and the RBT test, which was the initial Rose Bengal test. So now with ELISA tests, things are becoming much better. we are finding good IgM, good IgG tests. And in these chronic burnt out cases, you're not going to get any joy from culture because culture is long time over. So you absolutely have to rely on serology. And good ELISAs are coming up now.
Ma'am,
Are
any
they
data?
available? Are they available? Are the ELISA available now for Brucella?
They are all available. Good ELISA kits are available for Brucella IgG and Brucella IgM. They can even be done from the CSF.
Thank you.
Ma'am, there are a couple more questions. Can we take or shall we?
I think we should stop because
sure.
it's already 8:30. We have crossed beyond time. And I request all the participants to give your comments if you like this kind of panel discussions and case presentations as an academic event. And also I request all the participants to suggest the future topics which we can take up one by one at a later date. I really thank all the presenters who have presented excellently and the panelists for sharing their valuable time and making this academic session very fruitful. Thank you very much. I would also like to thank SIT's team for propelling the academics to a next level. Dr. Ram Subramaniam, Dr. Priscilla Rupali, Dr. Sunita Naredi for the excellent work they are doing. And people who are passionate, I urge upon to join the Clinical Infectious Disease Society. Thank you very much.
Thank you. Thank you for anchoring. Thank you very much, everybody.
Thank you very much, Kavita.
Thank you. Thanks to everyone. Thank you.
Thank you.
Thank you.
Thanks. Bye.